Welcome to Sticky Med, learning medicine, stick by stick.
Today we're taking a look at a stack of medical statistics and research papers. But instead of just summarizing them, we're going right to the ethical heart of the numbers. We hear the good news story in medicine all the time. You know the number? NNT, the number needed to treat.
Right, it's the hero statistic.
It's the hero statistic. It tells you exactly how many people you have to give a treatment to in order to, say, prevent one stroke or save one life. It's really intuitive. It's optimistic.
But if we only ever focus on that, on the benefit, we are missing half the picture. I mean, to truly be well-informed about medicine, you have to understand the counterpoint.
The villain.
Exactly. If NNT is the hero, we are diving into the villain today. NNH, the number needed to harm.
Okay.
So our mission is to take you through the technical details, but, make them simple. We need to understand not just what NNH is, but how it's calculated, why its interpretation kind of flips the script on NNT, and really the most important part.
How they work together.
Precisely. How these two numbers are weighed against each other to ethically decide if a drug is safe and effective enough to use. This benefit-risk calculus is, well, it's the secret language of prescribing.
Okay, let's unpack this. I think the best way to start is with a concept that makes this immediately relatable. Let's talk about the bad lottery.
A great analogy.
So imagine you have a pill. Your doctor says it's highly effective, but it has a specific serious risk, maybe, say a 1 in 100 chance of causing stomach bleeding.
Right.
Every time you take that pill, you are basically buying a ticket to this bad lottery.
Most people, thankfully, lose that lottery.
Yeah.
You take the pill, they get the benefit, and they're completely fine. But NNH, it quantifies the odds for the one person who wins.
The unlucky winner.
The one who experiences that specific bad outcome we're measuring. Formally, the number needed to harm is the number of patients who need to be exposed to a risk factor, the medication, to cause one additional bad outcome.
Additional is the key word.
It's the most important word. It's answering the question, how many people must I treat with this drug before I create one specific harm that, wouldn't have happened otherwise?
That makes perfect sense. But it does raise a technical question for me. We know NNT comes from something called absolute risk reduction, or ARR. If NNH is the evil twin, as researchers call it, is it calculated the same way?
It's very similar, but it changes slightly because you're measuring two different things. NNT uses absolute risk reduction, ARR. That measures how much the drug reduced a bad outcome.
Right, that's for benefit.
That's for benefit. NNH, on the other hand, comes from the attributable risk, or AR.
Attributable risk.
And that's the measure of the percentage of risk that is directly added by the intervention. So you're looking at the difference in the rate of the bad outcome between the drug group and the placebo group.
So it's the same idea, just looking at harm created instead of benefit created.
You've got it. Conceptually, the formulas are identical. Just one measures benefit and the other measures harm.
That distinction, that we're measuring the risk the drug created, that's fascinating. But this is where the stats really become a matter of ethics, right? The rounding rules.
Yes.
When we calculate NNT, the benefit, we always round up. So if the math says 5.2, we tell you the NNT is 6. We're avoiding overpromising.
It's being conservative. But for NNH, the number needed to harm, we completely flip that rule. We have to round down.
And that feels so counterintuitive.
It does to a lot of people.
If I calculate the NNH as 20.8 and I round it down to 20, I'm actually reporting a worse outcome. Why is assuming more harm the safer choice?
Because safety always dictates conservatism. If the calculated NNH is 20.8, that technically means you hurt one person for every 20.8 patients. If you round up to 21,
you might be understating the danger.
You're making it sound safer than it might be. So by rounding down to 20, we are choosing to report the absolute maximum potential risk. We're saying, look, it is safer to assume we will hurt one person in every 20 than to assume it will take 21.
So it's a rule to prevent gaming the system.
It prevents researchers, pharmaceutical companies, anyone, from massaging the numbers up to make a risk profile look just a little bit better than it is. It's the core of the conservative approach.
Okay. So we have our final conservatively rounded NNH number. How do we read it? Because the interpretation is the complete opposite of NNT.
It is completely inverted.
With NNT, the hero number, a low score is wonderful.
Yeah.
NNT of 5 means it's really easy to help someone.
Right.
With NNH, the number needed to harm, you want the exact opposite. A high score is good. NNH of, say, 5,000 means it's incredibly difficult to hurt someone. The drug is very safe.
Let's translate these numbers using scale, because the magnitude tells the whole story.
Okay.
If you see an NNH of 5, the verdict is unambiguously dangerous. You're hurting 1 out of every 5 people you treat.
Which sounds horrifying.
It does, but context is everything. Think of aggressive chemotherapy. The NNT for survival might be 2 or 3. You save 1 person for every 2 or 3 you treat, but the side effects, like severe nausea, might have an NNH of 5.
So it's a calculated, necessary danger.
Exactly. The drug is dangerous, but the disease is worse.
Okay, moving down the risk scale. What about an NNH of 50?
This is still classified as risky. You hurt 1 out of every 50 people. A classic example here might be a common but severe side effect from a maintenance drug, like constipation from high-dose opioids.
Something that really impacts quality of life.
For sure. It affects a meaningful number of patients, about 2%, and that NNH of 50 immediately raises flags for a doctor. They need to manage that risk.
And finally, the gold standard, NNH of 10,000.
Now you're in the safe category. You have to treat a literal army of people just to find 1 harm. This is the realm of drugs we trust every day.
Like Tylenol.
Like acetaminophen, yeah. The risk of it causing serious liver failure at normal recommended doses. The NNH is immense. The risk is so tiny that we consider it safe for the public.
This all leads to the ultimate decision point, the benefit-risk ratio. You can't look at NNH alone. And you can't look at NNT alone, it's the ratio. And this gives us the Goldie rule. For any treatment to be ethical, it has to be significantly easier to help than to hurt.
Let's run through 2 clear scenarios to make that stick.
Go for it.
Scenario A, the good drug. The NNT is low, let's say 5. The NNH is high, maybe 100.
Okay.
The simple translation is, I help 1 person in 5, and I only hurt 1 person in 100. The benefit is 20 times greater than the harm. You prescribe that all day long.
Now, scenario B, the bad drug. The NNT is high. You have to treat 100 people to get 1 benefit.
Right, and the NNH is alarmingly low, say 20.
Oh, wow.
When you translate that, it's terrible. It means I have to treat 100 people to save 1, but I will hurt 5 people along the way.
Because 100 divided by an NNH of 20 is 5.
You're causing harm at 5 times the rate you're creating benefit. The verdict is absolute. Do not prescribe it. The harm is easier to achieve than the help. That is a statistical failure.
This math is the backbone of major public health guidelines. We see it play out in these huge, real-world debates. Let's look at daily baby aspirin for stroke prevention in healthy people.
A perfect example.
For the benefit preventing 1 non-fatal stroke, the NNT is massive. It's 1,667.
Yeah, you have to treat almost 1,700 healthy people for years just to prevent 1 stroke. It's a very rare benefit.
Now for the harm, specifically causing 1 episode of major bleeding, the NNH is 3,333.
Okay, so mathematically, if we apply the golden rule, the NNH of 3,333 is higher than the NNT of 1,667. It's about twice as hard to harm someone as it is to benefit them.
So from a purely statistical view, the benefit outweighs the risk.
It does.
But the scale of these numbers, they're both in the thousands. The benefit is rare, the harm is even rarer. So why are so many medical guidelines still mixed on this? What does the math miss?
The math misses implementation. It misses practicality. When both the benefit and the harm are that rare, the logistics of prescribing it to millions becomes the sticking point. If you treat 1 million healthy people, sure, you prevent about 600 strokes, that's great. But you'll cause about 300 major bleeds. And while the ratio is favorable, that's still 300 catastrophic events.
And you have to get 1 million people to actually take a pill every single day.
Right, the compliance issue, the cost. Doctors often conclude that the tiny, tiny benefit just isn't worth the hassle or the aggregate risk when you scale it up. It's the difference between something being technically safe and societally worth it.
That is such a critical distinction. Okay, to make sure everyone can apply this, let's do a practice calculation step by step. Let's use a simple study, a new painkiller causing stomach ulcers.
Let's do it.
First, we need the baseline risk. The people in the placebo group who didn't take the drug had a 2% rate of stomach ulcers. That's just the natural risk.
Okay, 2% baseline. Now the drug group, the ones who took the painkiller, they had a 10% rate of ulcers.
So step 1. We calculate the attributable risk, the AR. This is the specific risk the drug added. So we take 10% minus the 2% baseline, and that gives us 8%.
Exactly. 8% is the risk that is attributable solely to the painkiller. Step 2 is to calculate the NNH. We just take the inverse of that attributable risk.
So we take 8%, express it as a decimal, 0.08, and we do 1 divided by 0.08.
Which gives you 12.5.
Step 3, the ethical step. We apply that critical rounding rule for harm. We have to round down, so 12.5 becomes 12.
Becomes 12. And step 4 is the interpretation. The final NNH is 12. And that means,
For every 12 patients I treat with this new painkiller, I will cause one new stomach ulcer.
and knowing that, a doctor can immediately weigh it.
Mm.
If the NNT for pain relief is, say, 20,
The decision is obvious. You're hurting people more easily 1 in 12 than you're helping them 1 in 20. Don't prescribe.
that's the clarity we're aiming for.
It is. Let's finish with a quick summary then of these key metrics.
Okay. Think of NNT. How many to save 1? Good score is low. The math is 1 divided by the benefit, the ARR.
And NNH, how many to hurt 1? The math is 1 divided by the harm, the AR. Together they turn raw data into ethical decisions.
That's the whole story.
And that brings us right back to those massive numbers with the aspirin example. NNT at 1,667, NNH at 3,333. We established that, mathematically the drug is safer than it is beneficial, but public health guidelines often pull back. So here's the thought I want to leave you with. If both the benefit and the harm are incredibly rare, what is the ultimate moral threshold? What defines the difference between a drug that is worth it and one that is simply not worth the hassle for an entire population? You now have the tools to assess the safety, but the true burden of rare harms versus rare benefits. Well, that's a decision to mull over every time you read a health recommendation.